Thank you. Welcome to the Shropshire CCG board meeting. I'd like to welcome some new members of the board. We have Chris Morris, who is our new Director of Nursing and Quality, who's in a joint position with Telford and Wrekin. We also have Rachel Robinson, who is the Director of Public Health from the Council, so welcome. And also we have Colin Stanford, who is our new lay member on the board. So welcome to you three to your first official board meeting. We have some apologies, from Gail Fortsmeyer. Just need to run through any members' declarations of interest. They're all on the website, so unless there's any, I'll go around the board and just look around, and if anyone's got any extra declarations of interest above and beyond what's already declared on the website, then just let me know and you can then speak. But Rachel, do we have your declaration?
You probably don't have mine, so I probably will need to update that and declare obviously that I work for Shropshire Council.
Yeah, no, thank you. Anyone else? No, that's fine, thank you. So the introductory comments, well, I think this meeting follows on from the AGM, and we obviously had some discussion there about last year's performance. I don't think there's any more to be said other than this meeting is going to give us our first cut of our finances for this year, and also we will have an update on some of the key issues that around quality and henceforth and ambulances that are on the agenda. So I think if we move straight into the meeting. And the first section is just members checking the minutes for accuracy and correction. So if I go through those, pages 1 through to 5, and then 5 through till 10, 11 through to 15, and then up to the final page, which is 17. If not, we'll accept those as a true and accurate reflection of the meeting. So thank you. We've actually had no public questions submitted for this board, so we'll move straight on to the actions arising from the Governing Board meeting on the 8th of May. I think all the actions are now completed. So we had the first one was just about a layout, which has been done, and then we had some updates to the Governing Body, which are coming back to today's board meeting. Likewise, an update on the Learning Disability Mortality Review, which is in the quality paper, so that's for this board meeting. There is some feedback for matters arising around the CCIO role, and I think David was going to talk with Gail and the STP lead.
So where we are there, Chair, is we've developed a role description for the role. I think we're still working through the process of how we'll fill that in practical terms, but we're making progress.
Okay, thank you very much for that. Next one was about the ambulance demand, which is on the agenda for today. Moving on to the second page, the operational plan has been discussed at the development session. There was the next one was Claire Skidmore was going to circulate a letter from NHS England as it arrived, and that was done back in May. There is a matter arising that's come back today from the surveys results with those from 2017 that Sam was going to answer.
Yeah, so we've looked back at the previous 4 years, and what that has shown us is that on the one occasion where we did call the GP practices and follow up with them, we did have a better response rate. So that's helpful, or would be helpful for future planning. Although it has now been announced that the 360-degree survey will not be continued. Given the changes that are now taking place in the NHS landscape.
Sorry, so nationally the 360-degree survey is being cancelled?
Yes, so there won't be another one.
Okay, that's fine.
Until they decide if they're going to do something else, as it stands at the moment, we won't be required to do it going forward.
Okay, thank you. Thank you. And then the final one has been completed. It was arranging a revision of the Quality Committee's terms of reference, just to change some of the titles, and that's being done. So we can move on to the next paper, which is the Governing Body Assurance Framework, and Sam's going to present that.
Thank you. The covering paper is fairly short and to the point, so I won't go over it in any great detail. There were some actions identified at the previous governing body meeting which are set out in the paper, which have been actioned. The main thing I wanted to bring the governing body's attention to is the reformatting of the document that we've pursued following a recommendation from our internal audit colleagues, which again I've set out in the paper, but just to reiterate, ensures that we have proper tracking through from gaps in controls and assurances through to the actions that we're taking to mitigate those, and that actions are clearly about things that we're doing in the future, where an action's been carried out and therefore is having a mitigating impact is then moved into that controls or assurances section, where it's noted to be having the impact that's intended. So I just wanted to draw that to the governing body's attention. Very happy to receive comments if the way that this presentational review has been done isn't hitting the mark, but hopefully it will enable people to see a clear direction of travel in terms of the work that's taking place to specifically mitigate the risks noted in the framework.
Okay, thank you. Just the first thing for me is the first two points on the GBAF. The column doesn't have an arrow showing whether they're sort of staying stable or increasing or decreasing. So compared to the previous GBAF.
So some of the arrows have fallen off.
But they're on, the first two haven't got arrows on. The key principle of risk 1, which is the finance, and risk 2, which is the quality and safety one.
Yeah, so we can make sure they're added.
I think the finance is a new one, isn't it? From
the finance is a new one for the beginning of this year, yeah.
The other one has been there, so that's fine. So we could just make it's just easier to be able to work out whether they've changed at all. So any questions or comments? David?
Yeah, I just pointed that to Claire. I had just one comment on the first risk around finance, around the risk that the CCG fails to deliver its control total. As we know, and we'll look at in our finance plan, our plan doesn't deliver control total. Therefore, I think it should be risk is that we don't deliver plan rather than control total.
Okay. Yes, you'll note that this particular risk also features on the issues log that's attached on a separate tab. Because it's a live issue, yes, that's right.
Thank you. Any other comments or questions? No, if not, then that's fine. Thank you, Sam. We'll move on to the combined finance, contracting and QUIP report.
Thank you. So members of the governing body will see that we've had quite a major overhaul of our reporting style ready for the new financial year. We've also taken the opportunity to combine the QUIP report into the finance report for reporting here, but just to give some assurance that at Finance Committee we are still continuing to take separate papers, and committee have the pleasure of ploughing through quite a hefty amount of information relating to particularly the detail around the QUIP schemes. So we still carry all of that information, but we're trying to make sure that what we present here to governing body is the most effective information that we can to help with decision making and assurance. Just one point of accuracy as well. One eagle-eyed reader pointed out to me this week that on paragraph 11 of the report there's a reference to some graphs that aren't there. Just to give an apology that that paragraph should have been deleted but wasn't, so disregard that one. It doesn't change the flow of the overall presentation. The first thing that I wanted to start with in terms of talking about the position for 1920 is to just flag how we've moved on in terms of conversations around our control total. So as David just pointed out, we know that we are not on trajectory to meet our control total for the year. We've set a budget based on a reasonable plan. We had discussions at this committee at our last meeting about what does it mean to sign off a plan that's not control total, and particularly when we hadn't had a view back from NHS England at that time about whether that plan was accepted. I'm pleased to say that NHS England have now written formally and confirmed their acceptance of our plan position. A copy of the letter is included with these papers for information. It comes with a number of requirements of us as an organisation. As you can imagine, we must strive to meet the plan that we've set, and also a lot of our duties around delivery of particular targets in year. There's nothing in there that is a shock or a surprise. It's all the things that we already knew that we needed to do, and we're working hard to deliver. But it does mean that we have that formal record that NHS England accept that plan position, which is really helpful from our point of view to know that we can continue to monitor our progress on that basis. You'll recall then that we are required this year to meet a planned deficit position of £22.9 million, and at month 2 we have reported that we will meet that, albeit we have an unmitigated risk in our position of around £5 million. So that means that we believe that if the risks that we've flagged do materialise, we wouldn't be able to find sufficient mitigations to cover all of that. And so we could be up to £5 million away from target. And I think it's really important to make that point early on. We are very early into the financial year, and we are already seeing indications that we have areas of overheating and overspend within our portfolio. That's borne out in our year-to-date position. So already at month 2, we were round about £2 million off plan. And that's been driven by 2 key areas at the moment. One is cost pressure in the acute sector, and particularly around emergency activity. We note ambulance conveyances here, but we're seeing non-elective activity overheat more generally, and also in MSK, musculoskeletal activity at Robert Jones. We've also seen a significant rise in costs within our complex care area, and particularly mental health complex care, which seems to be a stepped increase in the number of patients who are being cared for under Section 117 arrangements. We're doing some work at the moment within Chris's team and with the support of commissioners for mental health to have a look at why that's occurred. It's certainly a pattern that's been replicated in Telford as well. So as a system, we're trying to understand what's driven that change in activity to make sure that it's relevant and right. And obviously, if we do find anything there and we have to make changes, we'll then subsequently reflect that in the position that we're reporting. I think overall our QUIP plans are delivering well to date. We've got a number of schemes that aren't due to start until later in the year, so we're making sure as a management team that we're keeping on top of our plans and our delivery trajectories to make sure that they don't slip. I've mentioned MSK already. We have seen some slippage in the programme related to the SUS work at Robert Jones, and we have relevant working groups looking at that at the moment. I know Julie and others are involved in weekly calls with the Trust to make sure that we pull that project back on track. And committee members will recall that when we set the contract with Robert Jones this year, we entered into a risk share agreement with them around those savings. So both organisations have some skin in the game really to get that project back on track, which hopefully will help us. I think that's probably where I'll pause at this stage. That gives you a flavour for the difficulties that we're already seeing coming through in the numbers. As you can expect, the management team are working hard, both internally and with partner organisations in the system, to have a look at how we can control this position and try and make sure that we can influence those forecast trajectories where possible. It certainly looks like a challenging start to the year. It's not going to be easy to try and land this plan position. And it's, as I've been saying to the management team, it's not something that the finance team can fix on a spreadsheet. This is something that we've got to get out there into the system and really try and make a difference to the things that we do to see a change in these numbers. I'm happy to take any questions if people have them.
Thank you, Claire. So, questions from the board? Kevin.
Thanks, Claire. I just want to reiterate as chairs the finance and performance that we share your concerns, as you know, at a long meeting we had last week, but we're going to focus on some of these areas that we aren't performing particularly well on, together with our QUIP programmes, and we intend to do some deep dives on various areas. I think the next one we're going to do is around CHC, where we're going to look at, actually, we know the extent of the problem, or do we know the extent of the problem, and how can we work towards to mitigate some of these and get a plan in place. And then I'm sure we'll take on each area, possibly at MSK the following month, and hopefully we can get an action plan together.
Thank you. John.
Just going to ask Claire about the A1A SAF position on emergency activity, the graphs, just projecting the emergency actual activity from 18-19 in the blue line on that graph, and then superimposing the emergency plan activity for 19-20. It's just that it seems to superimpose rather than follow on from the 18-19 activity. Is that still seen as realistic, that we would drop back down to the beginning of 18-19 activity? Is there potentially a risk here that we may see activity increase along the blue trajectory?
That's one of the questions that we've lodged with the BI team at the moment. So because we can see that there's a variance from plan early on, we're going through a number of steps to test what's driving that. So first question is always, is the plan right? Not just in terms of its total, but in the phasing of it as well, because it may well be that the phasing has mirrored previous year, but actually that's not a true reflection of the position. So emergency activity in particular, we know we have plans for some schemes later in the year where we would see some of that activity drop. So it may well be that it's a phasing issue. But alongside that, we will do all the other tests in terms of the drivers of the spend and making sure that we're mapping that correctly.
Can I just ask a follow-up question to that? But Alan wants to speak as well. Look, when you look at those graphs on A1A, and I think John's point is quite key about just seeing people plotting the previous graph, whereas I think if we'd had previous years, we might have seen a more upwards trajectory. But it's more the difference between the ones we've plotted for A&E activity and the ones for emergency activity. We seem to have allowed for an increase in A&E activity and quite a big increase in A&E cost, but have decreased in some months the activity and decreased in most months the emergency cost. I was wondering what was our assumptions? Our assumptions were more activity was going to go through A&E, but there was going to be less admissions. I was wondering what was behind. I'm not expecting to answer now, but I was wondering, it does beg a question, is that right? That we'd, surely with more A&E activity, we'd expect more A&E emergency admissions?
Potentially, we can have a look to address those questions through the work that we're doing at the moment. We've already committed to bring some information back to Finance Committee, next committee, which will land before board. So we'll have a look at that.
And the big jump in A&E cost compared to the previous year, compared to A&E activity, is that what's behind that? Changes in tariff or?
There have been some shifts in tariff this year. I think there have also been some assumptions made around the mix of activity that's coming through. But again, I'll answer that specific question in future information.
It does lead on to a similar question, which again I'm not expecting to answer now. In A1B, which is around the RJH position, we're showing decreases in elective activity, which is fine, because obviously we've planned for that. But we're showing potentially big increases in first outpatient activity and big increases in first outpatient costs. So again, we're expecting to see an increase in activity in outpatients, but a fall in elective activity. And again, that strikes me as being sort of slightly at odds. I mean, I'm sure there might be an explanation for it. In isolation, it might be hard to explain. So I'm not saying I don't need to know what I can answer now, but it's just something that perhaps is worth.
We can test that. I think some of the outpatient work is driven by the modelling for SUS itself and
So
what
does this
follows through
include
from
SUS
that. But we
activity
can.
then?
I'll test. Yeah, I'll test that.
Sorry, Alan.
I don't want to give you the wrong answer.
No, I'm not asking.
And they're clearly the right questions. We need to understand really what's going on here, how our plan, what assumptions our plans had, and are they phased through properly. And what I always quite like is a rolling annual average as well, because that gives you, it smooths out seasonal variation, and admittedly it slows down the impact of any 1 month's change, but it gives you a slightly clearer perspective on what's happening over time. So I think this is a better presentation than we've had previously. I think we should recognise that, so that it's a lot clearer, but it leads to some perfectly reasonable questions.
Yeah.
Alan.
Thank you, Chair. Claire, you report an outstanding dispute with the Betsy Cadwallader Health Board.
Yeah.
Could you say something more about the nature of that dispute and the magnitude of it?
Yeah, no problem. So last financial year, they amended their pricing arrangements, but didn't serve sufficient notice according to English contracting rules. Unfortunately, because they're governed by Welsh rules, we had a difference in opinion in terms of the timing of when those price changes could impact. We had a series of discussions with them over the year, and at the end of the financial year just gone, those hadn't been resolved, and it was likely that we would have to go through arbitration with them, which would have been quite a challenging position. We've gone back to them, and they've been in touch recently to have another look at it now with a view to avoiding an arbitration position, and particularly because you can't lock down a contract for 1920 until you've settled previous years. And I'm pleased to report that we've had some very positive conversations with them in the last couple of weeks. There is an offer on the table from them that I will be responding to this week, and I've had verbal agreement in terms of the numbers we're looking at, so 1819 should be closed very soon. That's also unlocked the discussions about 1920, and very early numbers that they've sent for the 1920 contracts certainly look, as I would describe it, within the realms of reasonableness in terms of what we would have expected. So conversations are still very much ongoing at the moment, but definitely in the last 2 to 3 weeks have progressed quite significantly.
Quantum of the dispute.
So the impact of the dispute, it's difficult to define a quantum because, as you can imagine, they had a view of one number, we had a view of a different number, but the settlement that we've discussed, we've already got modelled into our position at the moment, but would move our payment from last year by 300,000, and that will settle and be done. We are looking at a quantum for the contract for 1920 of just short of 5 million, I think it is at the moment. So it's a fairly scalable contract, which is why some of these discussions have been quite challenging.
Thank you. Any further questions? I've got one question about Fran Steele's letter for David. The final point, this is the final page of the report, the final bullet point is the CCG should take all necessary actions to ensure that directions imposed on the CCG in 2016 are lifted. So the directions were to have a capacity and capability plan, which has been done, to have a medium-term financial plan at the time, and obviously any organisation has one of those rolling forward, and to seek their permission to appoint an AO and directors and the level below that. So I'm not really sure what do they want us to do to have directions lifted, or is it just that they're planning to lift them and impose?
I think it probably relates to the question we were asked in the annual general meeting. I think it's a bullet point they put on any CCG that's under directions. I believe that the IAF rating that we expect to receive fairly soon is connected to directions as well. So in some senses, it's within their gift to take and to give and take away directions. So I think it's a catch-all bullet point, to be honest, rather than with any great meaning. As discussed earlier in the AGM, one of our actions is to set up a new CCG, which I think by rule of logic would have a fresh slate, as we said at the AGM. So I think in a way that's the simplest solution to this, is to proceed to establish a new CCG. Beyond that, I know not what that really means in any practical sense.
So Julian, my understanding was that what we were waiting for was NHS England to approve our medium-term financial plan. And as I understand it, although we've discussed various drafts over the last 2 years, that has never been formally signed off, and that has been the one sticking point remaining. So that is what I think is holding us off from getting out of directions. Is that correct, Claire?
That was certainly one of the discussions that I've had previously. I think by virtue of the fact that we have to submit our system plan in the autumn, there's a point in time where we can have that conversation with NHS England again. But I'm not sure whether that would resolve itself before the 31st of March. So I think the best we can do is keep working to build our plan as we're already doing, make sure that bolts into the system plan, and then we'll take it from there.
And connected to that, as we'll come on to later on the agenda, in establishing a new single commissioning organisation, we again need to submit a medium-term financial plan, and the sign-off of the new organisation will implicitly include the sign-off of our collective with Telford and Wrekin medium-term financial plan. So it all sort of takes you to the same point, probably, Keith, I suspect.
Yeah.
We're asked to 3 actions. One is to note the financial position of month 2. One is to note the financial challenge and the urgency required around developing further in the equip plans. And then the final one is to provide some reports and feedback on the new report. I think, as David said, I think it's a positive change. I do worry that it's quite light on some of the information around contracting, and certainly and I appreciate that maybe because it's early in the year, but certainly as things move forward and we've got contracting challenges, there may need to be more on there, really.
Yeah, other than the Betsy Cadwallader issue, there isn't anything of scale that isn't picked up anywhere else in the reports through performance and quality at the moment, but I'll make sure we feed that back into the team so that we can put that in as things arise that the board need to be aware of. And
one of the other things that NHS England fed back about our financial report was sometimes when we do go ahead and we're looking at risks is to sort of stratify them into least worst case scenario, best case scenario, most likely, and also have a rationale. So obviously that may not be relevant for this report, but it's just that we don't want to lose that, because I think we're going to need a bit more detail around some of the figures as we move forward.
Yeah, no, certainly as the year progresses and risks become solidified in effect, so and if these pressures we're seeing in month 2 are continuing, we're undoubtedly have to drill into significantly more detail than we have in the report at the moment, partly through the Finance Committee, but I think some of that will need to come back here, as you say.
Yeah. Okay. Any other comments at all? If not, then we'll note those 2 actions and the comments back on the report.
Thank you.
And I think if we move straight on to the quality exception and performance report.
This is a double act.
Governing body members will note this is our first attempt at combining our performance and quality reports. So one of the first things is obviously we're more than happy to take feedback from colleagues in terms of this is a first stab, and obviously Chris and I'll work together to build that in over the next few months as we work through this. If it's helpful, I'll make a start and take the key points of performance, and obviously Chris will chip in with the quality updates as required, if that's okay. I guess the first point to really bring to the governing body's attention is the deterioration in some of the cancer performance, particularly the breast symptoms 2 week in April, and to inform the governing body that actually that will get worse in May. On a positive note, however, I can confirm that after the planned care working group with Shrewsbury and Telford hospitals last week, we know that kind of bottoms out in May, and we do start to see improvement in June. And that's predominantly to do with a problem with consultant radiologist capacity. We know they have a substantive consultant that's due to commence in the autumn, but they had struggled for interim capacity, and that's what caused the performance to deteriorate in April and May. But they have been able to secure additional capacity, and we will see that improve from June. The other key specialty that impacts our cancer performance is urology, and again that continues to be a challenge, but we are seeing the benefits of the development of the strategic partnership with UHNM, and again we are seeing improvement in kind of systems and processes, and also some of the consultants that are employed by Shrewsbury and Telford hospitals are now getting training in using the robot at Royal Stoke. So again, that's really going to help us to be able to recruit additional urologists into the county and to provide that ongoing support for our patients. The Trust do believe that they are on track to maintain the recovery of the 62-day target from October, but until we actually confirm the detail around the breast radiology capacity, we don't have a firm recovery trajectory for the 2-week breast symptoms. I would like to point out to colleagues that that's not just a Shropshire issue. We are seeing that both regionally and nationally, and actually some of our neighbouring trusts are seeing performance levels even lower than Shrewsbury and Telford. So we are making sure that information is available to our GP colleagues, so when advising patients when they are making those referrals, we are trying to encourage patients to go to where the wait is shortest, but clearly that's also, you know, offset against convenience for them and their families. Was there anything quality-wise you wanted to raise on that, the 104-day performance, Chris?
Yeah, I mean, clearly we've got a process in place to oversee the 104-day waits. We know that the vast majority of those are related to patients whose pathway goes to tertiary centres, and through the Quality Surveillance Group, which is chaired by NHS England across the North Midlands patch, we have conversations with Cancer Alliance representatives and also with commissioners from UHNM to enable us to have that cross-challenge. Certainly we've put in a challenge that to ensure that Shropshire patients are not disadvantaged in their wait when they're being seen by providers in outside of our county, and we've had some assurances that that isn't the case, but it is something that we'll continue to raise. Through the harm performers, we've not identified any significant or any harms to patients by the wait, but clearly it isn't good if you're that patient and having to wait. So from an experience perspective, it's not good for that individual or their family.
Moving on then to A&E, as we've said, we've articulated in the financial report that clearly demand into our accident and emergency departments continues to increase, both in terms of walk-ins and in terms of ambulance conveyances. We have, however, seen some improvement in performance, and I do think it's a result of there's been some investment by the Trust in terms of workforce, so we are seeing more senior nursing posts in both emergency departments that's now starting to have real benefit. We are seeing improvement during the daytime in terms of as staffing improves. We have middle grade doctors that are due to start from September onwards, a few each month, so again just in time for the winter, thankfully. So we are hoping that workforce, that we are kind of turning a corner and we'll start to see some benefit of that. I think it's fair to say that improvement we've seen at the moment tends to be during the in-hours period. Again, because of staffing shortages, the overnight is still of concern. We've more recently done some pilots with our ESIST colleagues around implementing the new national programme of same-day emergency care, and that has seen real improvement. Obviously, we hadn't got the results at the time of writing the report, but that has given us some real benefit, looking at round about kind of 5%. Now, obviously, everybody's putting in an extra effort for those kind of particular periods, so that we won't be able to maintain that level, but there's certainly elements of that now both hospitals are looking to see what they can continue. And then over the next few weeks, and certainly in time for the next governing body, we should be able to measure what improvement we expect from that same day emergency care, and should certainly start to see that coming through in the numbers. So we are by no means where we need to be. We still need to be pushing hard to get over the 80% mark at the very least. But I think it's fair to say the A&E delivery groups for the last couple of meetings have certainly been the most positive that I've been to for quite some considerable time. So it does feel as if as a combination of staffing, improving systems and processes, we are getting some momentum. We clearly had some 12-hour trolley breaches in April, which again, although there was no harm to patients, that's a dreadful patient experience, and it's also unpleasant for family members who are attending A&E with their relatives. And we are very keen to make sure that that is absolutely minimised, and pleased to report we haven't had any since. And there's clearly, as we improve the systems and processes and the flow through the hospital, obviously minimising those 12-hour trolley breaches is a priority. With regard to ambulance handovers, again, we have seen some improvement. We still have a problem where we have significant volumes of ambulances pitch up at either department. But again, a combination of the same-day emergency care and continuing improvement in systems and processes, we are seeing a gradual reduction in those handovers. And we've got, when we come on to the ambulance report later in the board, there'll be some other actions that I can take the governing body through, which will hopefully continue to improve that position. Our 18 weeks performance continues to be compromised, not least by the escalation into day surgery units. I'm pleased to report, though, that since the beginning of July, there's no longer any medical patients escalated into the day surgery unit at Princess Royal, so we are starting to see pick up again in elective activity and some improvement there. We remain partially escalated into Royal Shrewsbury, but we are looking at other means of trying to deliver that capacity, so that again, we know that that is compromising patient experience, and we're also very keen to follow that through and to see and to check that through our usual harm pro forma process when the patients are seen and treated, that there's been no compromise to their outcomes as a result of any delay in their care. And then just finally, I wanted to just touch on mental health and then pass over to Chris. We have put the extra investment in to increase the percentage of for IAPT for the access target, and although colleagues will see that the performance in April and May was below the run rate that we need to achieve the 22%, to assure colleagues that that was just due to a delay in terms of recruitment for the additional staff. And we have seen that the run rate does improve from June onwards when they've had those staff in place. So we remain confident that we can achieve that improvement for the year end. However, what has come to needs to be brought to the governing body's attention is the MPFT have brought to both CCG's attention an issue with regard to a backlog of children and young people that are waiting for an assessment for autistic spectrum disorders. We have, both CCGs have been meeting with the Trust on an urgent basis to try and find a solution to that, and we've both agreed some investment that will reduce the waits, because some of those children and young people have had long waits of over 12 months, and we have prioritised investing to clear that as quickly as possible. However, we do need to do a broader piece of work that understands the real underlying demand for this service, what capacity, therefore, we need to commission from the provider, and also it is around skills and competency of staff to provide those assessments in the volumes that we need. So it's to bring to governing body's attention that there is an issue, that we are absolutely committed to resolve it as quickly as possible, but we do have to find a sustainable solution to this, and it will not be easy, because again, I don't believe this is an issue particularly related just to Shropshire. It's far broader than this, and again, some of it is related to workforce related challenges within that field. Happy to hand over to Chris.
Thanks, Julie. I mean, most of the quality issues that are aligned to those that Julie's brought to your attention are reported in the paper that you've got in front of you. I think in relation to the autistic spectrum disorder, we have asked the Mental Health Trust to consider a harm performer perspective. Whilst these children are not necessarily going to come to harm for longer waits, clearly their developmental issues are something which need to be fully explored, and we have asked the Trust to identify any risk that would be associated with that, which we are awaiting. The Safe Today process continues within Shrewsbury and Telford hospitals, so that we are on a daily basis looking at staffing of the two emergency departments and ensuring that the things that were identified by the CQC and the actions that were put in place are continuing to be followed by the Trust. Those issues are all monitored through the Safety Oversight and Assurance Group, which is monthly, chaired by NHS Improvement within SATH, which Jess and I are members of that group, along with our Health Watch colleagues. NHS Improvement are noting an upward trajectory in terms of the Trust delivering the Quality Improvement Plan, which is positive. As commissioners, we are testing out the quality improvement plans through the clinical quality review processes, and we've so far had a deep dive into the unscheduled care plan and the scheduled care improvement plan, which are demonstrating that the sort of from the floor up approach is having some impact in taking forward what are often quite basic needs for improvement. So we're also following that up through our monthly planned visits across the organisation, which I know some of you have been participating in. I don't really have anything else to draw to your attention. The main one was around the autistic spectrum disorder, which we've already covered.
Before I open it up to questions, can I just ask, I do agree making the papers smaller is better, but we need to be careful we don't miss things out and there's enough information to give adequate assurance. And one of the things that I think we're missing is one of the actions that we said was complete was the to bring back in the quality report about an update on the leader review.
So the leader
not in this report. We just said that as an action that was completed, that it was coming back to today's meeting in the quality paper.
Maybe that's my misunderstanding, Julian. The leader report went to the quality committee in a presentation earlier this month. So I wasn't aware that you wanted it at the board. Quite happy to bring that again.
It's still potentially an outstanding action from the last board meeting, which was to arrange an update on the leader review to be presented to the next governing body meeting, including data and assurance. I know you weren't here for the last meeting, so it's hard to, it's not an action for you in that, but it's just that I think we need to be careful if we're trimming down the reports that we actually do have the information in there that we need. Other than that, should we open up to any questions, or Deborah?
Julie, looking at the cancer performance, and you've referred to the areas that we know are a challenge, like breast and urology. I noticed for the first time in this report, or the first time that I remember seeing it, is that performance in children's cancer and gynecological cancer also seem to have fallen. Can you tell us anything more about behind those figures?
We've asked for some more information for the next meeting on that, because likewise we've not seen an issue there. In fairness to did you say gynae as well as children's? Yeah, we do see fluctuation in gynae, which again tends to be and similar in the children. It can be down to small numbers, but we have asked if there's anything underlying there. They haven't brought anything to our attention, and in the exception reports we got, there was nothing, there was no themes there, but we will keep an eye on that, and rest assured we'll report anything that comes through.
So Deborah, yeah.
There was another quick point I wanted to make, and it's really just about the way we've phrased something around the problem with the waiting list for autism assessment. In paragraph 70, I was a bit uncomfortable about just some of the phrasing. There's a sentence there: it's been suggested that families of children and young people with attachment emotional deregulation are pursuing a diagnosis when there is not ASD. That reads to me as if we're putting some of the blame on families, and I think that's probably a bit unfair. They're not specialists, they're families trying to look after distressed and children whose needs aren't being met. So they're quite right to pursue a diagnosis, and it's our job as commissioners to have a service to provide that. So it was just the way it was phrased. I think it could be interpreted as blaming families, which is not appropriate.
Not at all. Okay. That was not the intention.
Colin?
Can I ask about learning disability? We note that Shropshire performs better on health checks for patients with learning disabilities, performs better than the national average. but it's still only at 64%, which means a third of patients out there with learning disabilities are not being checked by their GPs. They're a very vulnerable group with worse health outcomes than many other groups. And I just wonder what action, if any, we're taking about that. I didn't see anything following from that.
There isn't at the moment specifically. I think it was one of the areas that we did in the board development workshop. We did identify it as an issue, and when we were doing our planning in terms of priorities, it was certainly on the long list. Again, I think colleagues will know it's something I've been particularly concerned about for a long time, and we've not been able to get to the bottom of that. What I have done is in discussions now as part of trying to have more closer working with our colleagues in Telford and Wrekin, so that it gives us extra capacity. What we've agreed in terms of how we've split mental health between the commissioners that we've got available to us at the moment is that it's allowed Francis Sutherland, who works for Telford, to focus on adult mental health and learning disabilities, and we've got Cathy Davies, who's focusing on the 0 to 25. So I'm hoping that having that little bit of extra capacity will help us focus on learning disabilities, because you're right, even though just because we're better than average doesn't mean that it's good enough, and there's so much evidence behind how that can compromise life expectancy for those individuals that we do really need to do something about it.
Thank you very much.
Finola?
Forgive me if I've noticed something that I should have noticed in earlier meetings, but I see on paragraph 39 we've included Shropshire's mean wait time separately to the, I presume it's the West Midland average for ambulance times. And I'm just wondering if that looks like a change to me. I welcome it, but I'm just wondering why we're starting to show those figures, given I gather we can't do.
I think that we've always shown those figures because the WS contract is based on their regional figures, but it doesn't truly reflect the Shropshire position. So since we've been recording these new categories of responses, my main concern about these is it doesn't show the tail, doesn't show the weight, and we all know, and there's been stories in the press recently about the long wait for ambulances, and I think that
and that's why they changed the measure to have the, so we have, as well as the mean does do that, but the 90th percentile is meant to give some indication of the tail. But you're absolutely right, and that's been challenged recently at both the local Health and Social Care Overview and Scrutiny Committee and at the Health and Wellbeing Board, and we have asked for more information from the ambulance service on those long waits.
So yes, at the last Health and Wellbeing Board, Julie and I and Rachel indeed were all at, there was quite a detailed breakdown by postcode of ambulance performance, which shows some, well, both consistent poor performance, whether in a rural area or a more urban area in Shropshire, but also some quite marked variation. I think they were the means and the
90th
percentile, I think, but some quite significant variation between different postcodes as well. So we do have quite a lot more information than this.
Okay, thank you. John?
Yeah, great. Thanks, Julia. Really nice presented paper. Just two questions and one observation, really. One was in the first question is in the cancer 2-week wait graph, in the cancer statistics graph. The cancer 31-day wait for patients where the subsequent treatment is surgery. I see we're doing really well, and yet at the end we're projected to drop off in terms of our performance for surgery for patients with cancer. Just wondering whether there's something in the system there that's being flagged as a problem that's coming through to us this year.
I mean, obviously that will be impacted by the 2-week performance. So if we see a deterioration there, then that knocks onto both the 31-day and the 62. So there is a bit of a lag there, but typically we have done. I'm not aware of anything particular, and we certainly, again, even when we've been escalated, there were no cancer surgery has been cancelled. It's been routine surgery. Any clinically urgent or cancer has been maintained.
Okay, thanks. And the second question was about the ambulance figures on page 9, and that was really just about the totals involved So those taking, for instance, the handover delays of more than 30 minutes and the year-to-date of 1433, comparing that with the England, is that the expected England total at this point? You know, are we really 16% of the national total?
I'm not seeing where we've got a national total.
Page 9 is under the I may have misread it, but it says England in brackets, and it gives percentages or numbers in that column. Which
I think that just means as in it's English ambulance activity, not Welsh ambulance activity. It's not. That's our proportion. It's not a national one, I don't believe.
I think the England bit only refers to that one box about the unplanned hospitalisation.
Yeah, and that's because I say that characterises
so
the English activity, not the Welsh. The 8997 was our CCG's previous year.
Okay, that's our CCG. No, that's fine. That's slightly better.
Crikey, no, we're not that.
And then the observation was on page 7 about maternity smoking at delivery. You know, that we're consistently above the national average of 10.5%, and we're running between 13 and 14% of mothers smoking at delivery. And it was really just an observation that, you know, this comes at the same time that we've lost help to quit services in this county, and that yes, I know there is a service for mothers that are women that are pregnant, but really the work needs to be done before that point, and there needs to be a service available for people before they're pregnant to help improve those figures. Really, it's an observation that it's sad that we've lost that service in the county.
That's true. David, do you want to update briefly on that?
Or Rachel might be able to say a little bit more detail than me, but you're right, we have managed to maintain the smoking in pregnancy service, which is what that specific statistic is relating to, and that might not have happened, so I think that's good news. In terms of the wider work, we're looking at, that's a short-term fix, so we're looking at how we might address that more in a long-term way, and that's part of the work on the MLS work that Chris and Rachel can talk about. In terms of the wider smoking cessation service position, I don't think that's changed in the sense that, as we've talked before, the public health budget has been cut nationally, and that's played through at local level. It's not just true in this county, it's true in many parts of England, unfortunately. In the longer run, if we are, as we work as an integrated care system and we start to take a population health view about how we use our collective resource, then we need to, you're completely right, we need to start to make intelligent decisions about where we deploy our investment in a way that best fits the needs of our population, and that could easily include investing in some form of smoking cessation service. I think there's an open question whether what we were funding was necessarily fit for purpose for the most effective way of delivering smoking cessation. That's a perfectly legitimate question as well. But Rachel, do you want to add to that?
Yeah, thank you. Yeah, I think you've picked up on a lot of what I was going to say. I mean, obviously, clearly this is my first governing body meeting, and we are in a really difficult position, and it's not where we would want to be. And as Director of Public Health, it's not where I'd want to be. We are under significant pressure, the council as well as public health, in terms of savings. So we've had to make really difficult decisions, and that means some of the mandated services. And you're right, smoking cessation is one of those, and Help to Slim we're looking at decommissioning of those services. As we've said, smoking in pregnancy, we recognise that is a big issue, and it's not just smoking services with the mother. As you said, it's actually around the family, and it should start preconception. So that's some of the work that we're trying to do with the local maternity system at the moment. We're working with Public Health England as well, looking at across the country at models of best practice around that, because I think the thing we're keen on is that this isn't just a public health issue, it's actually a system-wide issue, and we need to tackle it jointly. So we are doing that at the moment, and we will be looking at the other services as well. I'm going to work through with the CCG. I'm coming to now. Let me get the
Clinical Commissioning Committee.
The Clinical Commissioning Committee, and we'll be bringing papers to look at the impact of some of these changes, looking at inequalities and which particular groups that affects, and looking at service planning going forward. So I think not trying to brush it under the carpet, recognise that we're in a really difficult position, but how do we look at this going forward, and how do we tackle it collectively as opposed to kind of sitting in one place? And I think, as we've said, there is some work that needs to be done. We need to look at the evidence around need, but also the evidence around what works, because things have moved on quite a lot, and I'm hoping that we can kind of do that collectively. And I guess to that point, I was going to kind of bring up, I think it might be useful perhaps if I bring a formal update to a future meeting around some of the changes to the services, not just these services, but also some of the work that we want to do jointly together.
That sounds very
Is that-
positive, thank you.
No, that does sound positive. Thank you, Rachel. Any further questions? I've got a couple of small questions. One is, obviously, the breast 2-week figure is very poor, at 31%, so I was quite surprised to hear that it gets worse.
It does.
I'm not surprised. I can't see how it can get worse, particularly, but obviously it has done.
It'll be less than 13% in May, Julian.
Sorry?
It'll be less than 13% in May.
13?
Yes.
So that begs a few questions. What's happened to all these people who've not been seen, and have they managed to see them, and has there been any harm in the delay? And although they're unlikely to be any harm, what is the length of time they've been seen? Because obviously, if they're being seen in 15 days, then that isn't really a problem. But if they're being seen in 3 months...
No, I can give you the
possibly
latest
is a problem.
update. They updated us at the planned care working group that the longest that anyone was delayed, as in 14 days being the target, was 28 days. As of just over a week ago, they were down to 21 days, and I'm getting a weekly update as to how that is coming down, but that's entirely down to them having secured the radiologist capacity.
So, I mean, what are you... Some people around the table may know, but what do we do with our provider when they're not hitting such a fundamental target? What can we do? I mean, we're obviously working with them, but do we have any sanctions, or have we written to them formally? Because obviously we can't go and solve this problem for them, but it is a problem that came last year. We had a similar dip last year, and then we had a trajectory where we were going to hit the 14-day target, and that we were... And
they did for a while, and then they lost more capacity. And I said the breast radiology capacity is not just a Shropshire issue, it's broader than that, and that's why, in fairness, the radiologists they've secured substantively is from overseas, and that's what's added to the delay of them being appointed. We obviously do follow the contractual processes. We do have action plans, but again, as we've seen with particularly urology, that has been such that it is outside of the Trust's control. What they've done is developed a strategic partnership with UHNM to develop that, and there is also now Alison Tong, the Regional Director of Commissioning for NHS E&I, has set up a urological cancer review board that I think meets for the first time tomorrow, and that's about looking at the long term, looking at a needs assessment for urological cancer, understanding what that is, and then having to plan and make sure that we have got the workforce, the diagnostic capability to deal with that, because there's clearly a disconnect that's caused a problem. I think the other thing that we have seen in urology, which is something we're grappling with at the moment, is quite a number of voluntary sector and charity organisations do kind of, promotional events and try and, encourage testing. And that has caused a problem, because actually they mean well, but they're targeting probably the lowest risk element of the population, and then because then all of the referrals flood into the department, that then prevents the patients who do need to be seen and potentially diagnosed more quickly. They are impacted with that. So we're through the cancer group, they're trying to look and see how can we better interface with those voluntary sectors to have more of an informed dialogue, that if they are planning something like that, come and talk to us, come and talk to our colleagues in public health about how do we do that in the right way that's the best thing for our local population, but not compromising the precious resources that we do have.
Okay. One further question, if that's all right. Or two further questions. One is, I wonder why we measure 12-hour trolley weights as being a marker of quality, because every single time South have one, there's never any harm. So I do worry that we've had all these 12-hour... perhaps this question for Chris, how much in detail do we analyse their analysis of whether any harm has happened? Because we have had, over the year, numerous 12-hour trolley breaches, and I can't remember anyone ever being reported as a harm, which I do think is slightly odd.
Yeah, I do agree with you actually, Julian. I think the point is that when the harm performer is done, it's quite soon after the 12-hour trolley breach, so there will be a 72-hour review and then a short review of the impact on that patient, and sometimes it's further down the line that the patient may get a harm incident, so they may develop a pressure ulcer that sort of was caused by that long delay on the trolley, but actually materialises a bit later down the line. So clearly throughout the quality oversight and reporting that we've got with the Trust, we would be picking that up. But I guess it's more about the patient experience element that is the one to watch, which we don't have any metrics to measure.
And then one final question, sorry. Just point 61, which is midwifery. And on the face of it, it is a very simple statement of fact. The MLU RSH site is closed for essential building work, but that obviously on the back of all the other freestanding MLUs being shut means that we are just offering consultant unit and alongside maternity unit and home deliveries. And I was wondering what work we were doing with our providers over that. And obviously, it seems to be a surprise that it's shut. I thought they renovated the building only the other year, but I mean, that's obviously things change. But it's quite impactful, I would have thought, for our patients.
It certainly is. I mean, the Trust are managing the numbers of women presenting on a daily basis. They've given us assurances that there is capacity at the Wrekin unit to take all those women who wish to have a midwife-led birth. But I think they are juggling on a daily basis with capacity across the consultant unit and the midwife-led unit in the Wrekin. So it's not an easy solution. We have seen the home births increase slightly to 1.8% now, which is still very low, but that is still an option to women. I think the midwives are trying to encourage more women to safely have home births where the level of risk is low.
Is our birth before arrival, BBA, is that the right term? Has that changed? I mean, that's
no, it hasn't changed, no, and we are monitoring that on a monthly basis.
Good, thank you. Unless there's any other further questions, then I think we're just asked to note the contents of this report.
Again, this is one where we've changed format somewhat in that we brought the quality and performance reports together into a single integrated report, which we've kind of made 3/4 progress on, I guess, so it's still a little bit clunky, I think. But just checking that makes sense. It certainly makes sense to me because we often have the same data into parallel reports. So we'll continue to evolve it, I think, but yeah, as long as you're happy, this is the right direction of travel.
Thank you.
Yep. Thank you. So we move on to the ambulance demand review.
This is following on from a paper brought to May that showed all the analysis that we'd done around trying to understand the increase in the ambulance conveyancing. As you can see, we're still struggling to understand any specific causes to that other than the inexorable increase in public demand and dialing 999 and the consequence that has in terms of ultimately increased conveyancing. And what the group has moved on to then is to, if that demand is coming in through 999, then are there other things that we can do to manage that demand in a different way? So there's a number of schemes that are listed in here, and I just wanted to give a brief update on a couple since we'd written it. The strategic capacity cell, I want to say that obviously that was put in place by the ambulance service with the support of the regional commissioner, and all bar I believe the Staffordshire CCG supported that and are part of that process. We have recently piloted and put a very senior nurse into that to understand specifically the demand across Shropshire and Telford and Wrekin, so that we can see are there any gaps in services or any of the alternatives that we could be offering. That 5-day kind of test of change took place last week, so unfortunately it's too early to report the findings, but just to let colleagues know that that has taken place, and those findings will be reported via the A&E delivery group, and then we can use that to inform future commissioning arrangements and alternatives. I would say that the usual thing around, but the other thing we have found is we've been able to, we have improved the uptake of using minor injuries, and I know that we've had some communication from Mr Sandbach about an opportunity with an app. Absolutely. We know that just having a senior clinician in there providing that information is not sustainable. It's not the best use of their resources. Equally, we've known we had a paramedic line that was that we commissioned from Shropdoc that was never used either. So one of the things we've got to come up with is what is a sustainable way of ensuring that all of the ambulance crews, when they're in the county, know what that service provision can offer, and make sure that we're getting patients to the right place. So potentially an app is absolutely something that we'll put through our local ambulance group and consider. I wanted to update the governing body that our high intensity user service, obviously we did have a paramedic in place doing that post. Unfortunately, that individual chose to leave and pursue another career opportunity, but we have now got a new HISU worker in place, Catherine, who has now started and is now building up her local contacts and the caseload. So I'm confident that we will see an impact of that as we've seen previously over recent years. And there's definitely an opportunity to start to link that as Catherine gets up to speed, and we're working on that to link that with high ambulance usage as well and frequent callers. So we have got the connection in there with the ambulance service to optimise the use of that particular role. Then in terms of handover delays, I did just want to point out, I did mention earlier under the performance update the start of change work that was done around using the same day emergency care models, and to point out the really encouraging early data there that showed that we had a 41% reduction in the ambulance handover times in the acute medical unit, and a 13% increase in the number of patients handed over in terms of 15 minutes, which if you think about it, that's a massive improvement for patient experience, what we've just talked about. It's also, it's much better in terms of then releasing crews to be able to get back on the street and to respond to the 999. So in terms of, particularly for us in a rural health economy, having those crews back on the streets to respond to that can only be a good thing. So the important thing for us now is that we understand exactly what were the key elements of the SDEC work that helped us achieve that, and how can we make sure we embed that into our normal ways of working, and what are, if any, limitations around the 7-day delivery of that, particularly linked to, as we've mentioned before, workforce. But it has had a really positive impact. And we're also the halo that the CCG commissions at RSH, we've also agreed some evaluation criteria with our ambulance service colleagues. That has been in place since the beginning of this week, and all that data is being collected on a daily basis. Emma Pirate in my team will lead that evaluation in 3 months' time, and obviously we'll be able to report that back. I've suggested in this report that in terms of the regular updates of this, that we pass this through the Clinical Commissioning Committee in future if governing body members are happy with that. But obviously any major issues would come to the governing body as required.
Thank you, Julie. It's a nice paper to see with all this range of different schemes and services that are being offered. So, are there any questions from the board to Julie on this paper? Nola.
Thank you. Just around point 6 of the paper, I welcome any initiative that looks to ensure that people are treated the right place, right time. But given the strategic capacity cell, I was disappointed to find out about this service via governing board rather than through Shropshire Care Close to Home, where West Midlands Ambulance Service sits with us as a fellow partner. And each partner is invited at the end of every meeting to share with us any initiatives they're doing that may dovetail with work we're doing. There has been some attendance by the Ambulance Trust, although more lack of attendance than attendance if we were to count it. However, I'm sure they would have gleaned from being part of that transformation programme that the findings that the service is having limited impact should surely be no surprise to them, given we do have limited alternatives to conveying patients to anything other than A&E at the moment. And given this seems to have been a service that was commissioned outside our remit, it sounds like we've had no choice in this service running. Of course, it's important to understand its impact as we seek to roll out the services that we've been co-designing with all our partners. But I think it does illustrate that we do have system working, but sometimes it does feel as though
it's a bit clunky, isn't it?
It's a bit clunky, and we have to ensure that we're not that we understand exactly what's going on out there, so that everything dovetails together and we understand the impact of each service or initiative. And equally, I'd like this to be pointed out to West Midlands Ambulance Service that, you know, if they are our partner, they do need to factor in what we're doing and work with us rather than impose something we can't work. We don't understand.
We constantly reiterate that through our fortnightly meetings.
Thank you, David. Is there something that we can do then to feed back to West Midlands Ambulance around that?
Yeah, I mean, there's a theme, isn't there, around how we commission ambulance services given it's a regional service, and there's a obvious risk that A, we're not necessarily always at the table in those discussions, and B, the rurality question we touched on earlier may not be fully taken into account. So I think there is something around how we strengthen the way we interface with the ambulance service and with the regional commissioning of the ambulance service to make sure our issues are properly taken into account and addressed. So yes, I think in short, how easy it is to do all that, I don't know, but I think it's right for us to up our game on trying.
Yeah. Jess.
It's just a quickie, Jules. On point 4, there was a little bit of additional analysis done, wasn't there, around the increased activity, trying to understand whether the switch over to 111 and the arrangement there had an impact. And point 4 concludes that because the disposition rate from the GP out of hours is 2%, that it hasn't. And I just wonder whether that was the full question, because whether there was a concern or a perception that perhaps if people didn't feel that they could easily access GP input out of hours, that they would be more likely to phone 999 instead. So it's not necessarily a direct link from them contacting, but patients actually choosing to use a different route because of concerns. Whether that's been explored or understood.
That's always a possibility. All that we could do, because obviously it's impossible to evidence that, all that we could do, and what the analysis that we did was we kind of projected the activity before and after the switchover and saw if there was a material shift, because if we'd seen that and the public, we'd have seen at that point in the time in the July period when it's flipped, we'd have seen a stepped increase in the local usage of 999, and we didn't see that. What we did kind of see, I said, was the same overall level. It's just it flipped from kind of one source to the other, but the overall the rate of demand for that appeared to be broadly the same. But as I say, on that ever upward trajectory, there wasn't a spike at the point of the changeover.
So just for clarity then, when we talk about the overactivity, are we talking about overactivity versus last year's actual activity, or are we talking about overactivity versus plan and the problem with the forecasting again?
I think there's probably a combination of the two. Again, compared to last year, there's one thing that we're continuing to understand with the ambulance services. If I don't know if colleagues will remember, but there was a change over to the new what's it called, ambulance response program, the ARP method of how they were counting the activity, and we believe that because potentially for one call there might be there could be a 1 or 2 dispatches for that was kind of, if you like, artificially inflating the activity. We were reliably informed that that was being corrected for this financial year, and that therefore we would see a benefit of that in terms of that sort of activity correction. We were assured by the regional commissioner that that wasn't driving any additional finance because it was on the call and not the multiple dispatch. However, and this is what we have put a request into the regional commissioner, but as yet we've not had a reply. We don't seem to have seen that benefit that we were expecting of that, if you like, that rebasing of how they were counting the activity this year. That hasn't happened, and we've still seen this step change in demand, and that's one of the things. As I say, I know we have corresponded with the regional commissioner on that, and we've not had a response to my knowledge.
David?
Yeah, I think I'm right in saying, because I think it was said at the Health and Wellbeing Board, that our use of ambulances per head of population is actually lower than other parts of the country.
Yeah.
So we always have to put some of this in that context. So it's not that our ambulance is clearly growing. I guess there's a question, why was it low in the first place, and is an element of this anyway recurrence to the norm, or whatever the right phrase is, in terms of ambulance usage. So you just have to put, sometimes you have to put that wider context in some of these discussions.
Colin.
On page, Julie, on page 5.14, you reference the high intensity user service.
Yeah.
But I was surprised to see that the service wasn't being fulfilled, as it were, because somebody was absent from work or left the job.
They left their position, yeah.
But I just wonder whether this is potentially a big, it's going to have a big impact on response rates and so on, and costs in healthcare, whether we should have a contingency to protect the post in case this sort of situation arises again.
Yep.
I presume it's one person, but I mean, we perhaps need to factor some planning into that.
It is, and the plan was that colleagues in Telford and Wrekin went and introduced, well, we're going to introduce a similar service and appointed someone to equivalent, and that's where we thought we would have the crossover. Unfortunately, I believe the person pulled out, and Telford and Wrekin have gone for a different solution now. So we still need to have a conversation as to how do we protect this and ensure that we've got the right kind of coverage for this, because it is a key role, and we certainly saw, you know, in our some of our most vulnerable patients saw the benefit of this post. So it is really important that we protect that. But the obvious way of getting that cover was obviously with Telford and Wrekin colleagues, and we've just got to rethink that a little bit. So we did have a plan, and now we need another plan.
Okay, thank you.
Finola.
Just to add to that, do we build in anything around resilience or support for that particular individual?
Yes.
Individuals? Because I would imagine it's quite an intense.
It is,
role,
absolutely.
and,
Yeah, no, we do.
Okay.
Unless there's any further questions, and we're asked to note the contents of the report and request that the further updates on progress against the action plan are taken back to the Clinical Commissioning Committee quarterly. That's fine. If we now have our break, which is a little bit later than planned on the timetable, but if it's just after 2:45 now, if we have some coffee and tea in the other room, then we start again at 3. Thank you. And thank you. If we can
both end up facing each other.
start again.
It's very lovely.
If we pick up where we left off with paper 96, which is the West Midlands Quality Review Service report, which Chris is going to present.
Thank you, Chair. So some of the governing body members will have been involved in this review. It was commissioned by NHS England, who wanted an independent review on both this CCG and Telford and Wrekin CCG's quality functions, mainly after some of the quality issues that were raising their heads across our providers last year. So there was a considerable amount of work went into pulling together documentary evidence around the key lines of inquiry that were shared with the CCGs from both teams, and a number of you were involved in the interviews and telephone calls and discussions with the 10 senior leaders that came from across the West Midlands to look and scrutinise our processes over a 2-day period. I think what the report presents is some good assurance around our quality functions across both CCGs. It highlights their words around the really effective collaboration that was in place at the time around the 2 quality teams across the county and how we use those resources. It identifies areas of good practice, particularly around serious incidents, looked after children monitoring processes, which were a struggle in the past, but I think is testament to the work that's gone on in our teams to improve that. We were praised for our safeguarding approaches on both sides of the county and our the leader programme, and I will bring the leader report to the next meeting. And also our quality functions around primary care were praised, and how we use business intelligence. I think there were some areas for improvement, as you would expect, and they were mainly around processes. So the reviewers suggested that we had a joint quality strategy in place across the two teams, and that we looked at a joint quality strategy and a joint escalation framework. So at the time, Shropshire had an active quality strategy and Telford and Wrekin had an active escalation framework. So now that we're working as one interim quality team, what we plan to do is to do some work around looking at best practice across the country, but also looking at the good work that has been recognised on both sides and pulling those together to a new suite of documents that actually formalise the work that we're doing around quality monitoring, and looking at how we build patient stories into our everyday work, rather than having a patient come and tell a story to the board and then leave. So it is our plan to build those through our reporting processes, which you will see in coming months. I think they spoke to our providers throughout the review, and our providers shared with them that they had good relationships with the CCG quality leads. Now that's not to say that they're not challenging, but they were effective working relationships with a respectful challenge, and that providers would welcome a single quality voice. NHS England themselves were welcoming a single quality voice. So where we are now is that we have got that interim structure. We have looked at all of the quality functions that need to be done across all of the services that we commission, and we've realigned our quality leads to cover that and to reduce the duplication that there was previously across Telford and Wrekin and Shropshire CCGs. So that's then freed up some capacity to be able to look in a bit more depth at some areas that didn't have named leads. So, for example, end-of-life care and frailty, we've now been able to assign quality leads to look at those areas of work specifically. So I think that's brought with it opportunities to increase our oversight, which I'm sure the board will be pleased to hear. So I'm happy to take questions. Our next steps, Quality Committee did review this report at its last meeting, and we agreed that the actions from from the report which I've just discussed around systems and processes, documentation aligned to a joint team would come back to the September meeting for review and agreement. So if board's happy, then I will continue with that course of action.
Thank you for that. I thought it was a very positive report overall and reflects all the work that you've previously done in Telford and that Dawn Clark and then previously Barbara Beale have been doing in Shropshire. So I think it was very good to read. It was good there are some action points and some things that we can improve on, but overall I think it sent out a very positive message that what we're doing as organisations and then coming together is the right thing to be doing, and we should be I think we should acknowledge the hard work of your team and the previous work that Dawn and Barbara had done. So thank you. Any questions about the report? If not, thank you. Then we'll note the contents of the report, and I think if we can note our thanks to for leading the Telford work and Dawn for leading the Shropshire side, that would be good. Thank you. And then we've got an update now on the future strategic commissioning arrangements.
Thank you. So the paper you've got in front of you summarises progress to date. So I'll just sort of rattle through some of the headlines and then open it up for comment. So as you'll remember, we made the decision at the last board to proceed to put forward the proposition of dissolving the 2 existing CCGs in the patch and forming a single new commissioning organisation across Shropshire, Telford and Wrekin. So where we're at in terms of progress on that, probably the most significant action is the progression of the appointment of the accountable officer to work across the 2 CCGs. Julian is working with Joe, his opposite number, in Telford on leading that process, and the interviews are scheduled for the 23rd of July. So that's obviously quite soon. So that will be a big step forward in this feeling like a real shift in how we're working. That said, as Chris has already said, you can see both in finance and in quality, we've already started to bring our work together, and it's starting to pay dividends in both cases, I think. The work to actually submit the application for forming a new organisation is not insubstantial. As often is the way, NHS England have developed quite a comprehensive and detailed set of key lines of inquiry and submissions we will need to make to support our proposition, which will be submitted by the end of September. And they're not a trivial set of pieces of work to do. So to support our work to deliver that, and the sorts of things I'm talking about, as well as setting out clear governance structures and constitution and process for appointing establishing the new governing body and putting in place a new management structure and all the underlying structures that will support that, and therefore the structures our staff will need to go through to establish a new organisation. As well as all of that, we will need to submit a medium-term financial plan, which I alluded to earlier, which will cross both organisations. So it will be an integrated medium-term financial plan, a commissioning strategy for the new organisation, a whole load of financial work to establish shared ledgers and all the rest of the technical details that Claire could describe much better than I can. So there's an awful lot of work to do in a relatively short period of time, and there are a number of checkpoint processes we are going through with NHS England. And we've been very clear with NHS England that our objective is to achieve the new organisation by the 1st of April 2020 if we possibly can, but we completely recognise that as we go through these checkpoints and as we are required to put in place all the submissions that we need to make, if at any point the honest view is we are not going to securely hit that timetable, then we also have a perfectly clear plan B, which is we will proceed to implement the integrated management team in time to be operational by the 1st of April 2020. But if we're not in a position to have formed a single organisation, we will continue as 2 organisations, but we will need to put in considerably more shared governance than we have currently. So there is an alternative, in other words, if we are unable to hit the deadlines that we're being asked to meet. But right now our objective remains to hit those deadlines. So to support that work, alongside the appointment of the accountable officer, we have now established a small PMO, Programme Management Office, to support the work which we've commissioned from the CSU. That's now in place. Alison Smith, who's Sam's opposite number, is taking a lead, is the lead SRO, I think we've called her, for this work across the two organisations, so we're not having two versions of the same plan, it's one integrated plan. We've put in place some additional HR capacity from the CSU, recognising that there'll be a considerable HR demand for managing change, which is often the most, if you get it wrong, you regret it at length. So putting that capacity in at the outset is definitely the right thing to do. And we're in the process of securing some OD support, and Sarah, you're going to help us with the recruitment of that. So we're going through a procurement process at the moment. And the aim of that will be to support us in both the engagement with our staff, our partners, our members, you as governing body and the executive team, on what kind of organisation are we trying to design, and then helping us with the actual design of that organisation. And we just recognise that while we possibly have most, but not necessarily all of those skills inside the organisation, we don't have the capacity, even if we do have the skills, and I'm not convinced we've got all the skills we need to do that. So that with HR support, with a PMO support and with some OD support, that puts us in a more realistic position to achieve the goal that we've set out. We're engaging with members already, so Julian and I will be going to each of the locality meetings to start we have already done some of this in truth, but we're going for the next round of locality meetings with our member practices who are key parts of the decision making on this process, to debate the rationale for putting forward what we're putting forward, listening to the sorts of issues they may have concerns about, and making sure whatever we put in place is addressing those issues. So again, the OD work will pick up on this in a greater pace, but we'll be starting those conversations in the next few weeks to make sure we're hearing member views, because we will before we submit the application, we will have a formal testing member support for the proposal to dissolve the existing CCGs and our CCG and to set up the new one. So that's some headlines. I'll probably stop there and very happy to take questions.
Thank you. Questions from the board? Alan?
Yeah, thanks, David. So will the governing body be given an opportunity to make suggestions as to how the new organisational structure should look?
Yeah, so the OD piece I was talking about will include speaking to you as governing body members, so absolutely. So what we're trying to do here is to build a new organisation, and that doesn't mean we replicate what we're doing now, but it certainly means we need to learn from how we work now, and if there are strengths and weaknesses in how we operate, we want to know both. We want to know what we absolutely want to build into the new organisation, and conversely what we absolutely think we should do differently because it hasn't been as successful as we'd like, and that's across both CCGs. So yes, is the short answer. And in timing terms, we hope to have our OD support in by the 1st of August, and then critically over that next couple of months in August and September is the key time to be influencing the future design of the organisation. It won't be the last opportunity, but I think it's quite important we have a clarity of objective by the time we make our submission at the end of September.
And will we be constricted by constitution?
Well, we need
to follow. Or?
We need to. One of the things we need to do is produce a new constitution for the new organisation. We will be bound by some NHS England requirements. I dare say we're not able to simply design a radically different organisation which ignores all the rules of the NHS. But clearly, if there are, again, issues in our current constitution which are within our powers to amend and we collectively think we should, then absolutely that's for discussion.
I think the other thing is we need to allow the new CCG the opportunity to shape itself in its own direction as well. So it's a balance between not setting things in stone, but also giving some guidance about what we think has worked and hasn't worked, and then the new organisation as it comes on stream, setting itself up. Really.
So we're imagining, in other words, that the Constitution is permissive of change in the future, so it's good enough to get it going, but allows it to evolve relatively quickly in terms of how it wants to operate as an organisation. Because we're in this funny stage where we as a outgoing organisation are designing a new organisation for leadership that doesn't yet exist, which is challenging, but I think the alternative is going much slower, and as we discussed back in May, I think that on balance the pretty strong view was crack on with this and design it as you know, if we can hit this deadline sensibly, then we should.
Meredith.
Thank you very much. Two items. I mentioned it before. I don't think I've seen anything around estate in any of the work streams, and I dare say it's somewhere, but I don't see any reference to it, and that's clearly an important element to the new arrangements. And the other thing is, it feels as if the recruitment process is proceeding, going along nicely, but I don't think we've seen anything about process, you know, who's involved, in what way are they involved, what the arrangements are for the kind of interviewing and the assessment system and so forth. It just feels a little bit cloudy at the moment, so I don't know if there's anything you can say about how it's being managed.
So we can do, I will do, I'll tell you, I'll describe the process. We are, going back to David's point, we are tied by the fact that this new organisation will be a completely separate organisation to the current organisations. There are some clear roles which you have to have through the Health and Social Care Act in terms of what your board's made up of clinical representatives from the practices, and you've got an AO, a CFO, and you've got a secondary care doctor, and you've got a board nurse, and you've got lay members. So, and we also have to follow the advice of NHS England, or try and work with the advice of NHS England. So what we agreed in May is that whether or not we move to a new organisation or not, both CCGs had agreed they would go to a shared management team. So if this doesn't work and NHS England or our members don't support us moving forward in April, then it will be that we will switch the CCG to having a single management team led by an AO. So the recruitment of the AO is more straightforward because we're going to have a new AO. So both boards have agreed, you know, David's contract is for a year, and Telford and Wickham agreed they would appoint a joint AO. So myself and Joe are working with NHS England and with the CSU HR team, and we aim to try and get this person in post sooner rather than later so that they can actually lead the formation of and guide the formation of the new CCG. So the process is led by Joe and myself jointly, and it's done in conjunction with Fran Steele, who's our area director for NHS England, and I, because ultimately the AO has to be signed off by, we can't appoint an AO, we can make a recommendation about who we want to be the AO, but Simon Stevens signs off the appointment. So we're working with NHS England. We have, as in the previous recruitments of the AOs, we've designed a process that has our partners involved in the selection, and also some of our colleagues in the board, and also our staff. So the selection, the shortlisting will be done by the interview panel, which is going to be Joe, myself, the two chief execs of the councils, and Fran Steele from NHS England. And then there'll be, as well as an interview panel with us, there will be two stakeholder panels that will be made up of a mixture of Health Watcher there, some other members of the CCG boards, the staff, as I say, and our partners. And then we will make a recommendation through NHS England up to Simon Stevens about who we think is appointable into the AO role. And then once the AO is there, they will become, at some point, depending on their notice period, they would become the joint AO. So they would take over the roles that are currently Dave Evans is in and David Stout is in. And then at the same time, if we've going through our process and we've got membership support, we'd have applied to NHS England for approval to create a new CCG. And then one of the first steps we need to do is appoint a new chair. So there'll then be a process that will be agreed, although it's not the responsibility of the current CCGs to decide the constitution of the new CCG, we'll help set up a structure that can actually arrange to appoint a chair, because that new chair has to then appoint the AO into the new CCG. in a sort of a convoluted way, and then also choose both sides and help sort of set up both the executive side of the organisation and the board side of the organisation. So that's the process.
And all of that explains why we're trying to make the AO appointment the first step in this process, because it's a lot easier when said person's in place than now, where we're trying to pre-design it for him or her, in effect. I think you asked about estates as well. So, by which you mean the offices out of which the CCGs operate, presumably. So yes, I think you've asked that once before. Yes, that will be one of the tasks that we will need to resolve, is what physical office space that we want to operate out of. That's not necessarily only one base. There may be, given the place space activity that we're expecting to continue, that we may need to maintain physical presence in both parts of the integrated patch. But either way, there's some work to do on, one, we need to define what we want, but two, we recognise, certainly from a Shropshire CCG point of view, that the offices we're operating in now are seriously suboptimal, and whatever the longer term solution is, it would be good to have a solution which is better than our current one. So Sam is doing some early work in relation to potential to move out of William Farr House one way or another.
I mean, as you can imagine, that's very much linked to what our structure is going to look like and our staff numbers. The things are overlapping really as we move forward.
And it won't necessarily all happen. It doesn't all have to happen by the 1st of April. There can be a lead-in time, and because of leases and things like that, there almost certainly would be a lead-in time if we did anything particularly radical. But it's definitely part of the work, yes.
Okay, thank you. Any further questions or comments about the process we're going through?
So my plan was to bring this back on a regular basis, both to the formal board meetings and to the development sessions. Keith, I think you were asking about, well, where else will lay members, but I guess the whole of the governing body, hear about progress? And clearly around things like finance, there may be a need to take to certainly finance committee, potentially the audit committee and so on. So as the work progresses, we will make sure it navigates its way through the normal governance structures we have as relevant, because as Julian's already said, some of this really isn't the business of the existing CCG, but some of it clearly is.
So thank you. So we'll note the contents of the report and the ongoing plan that you described about bringing information back to us. And then we move on to the next report is an update from Keith Timmis from the audit committees from the 21st of May and 26th of June.
I'll take the level of excitement as low, seeing as this says audit, but the report hopefully is clear enough, but there are three main areas I just wanted to highlight for the governing body. We've completed all the accounts and annual report processes. We got unqualified accounts, which is good, although we had an adverse conclusion on the value for money conclusion, which will come as no surprise given previous reports from Will Hutton about what we were expecting. Because we overspent, we also had what's technically called a Section 30 referral, which we've had in the last few years. On a more upbeat note, we did have some very positive comments from the external auditor about a lot of the finance department processes, and while no self-respecting external auditor would say they were happy, they were pleased to note the improvements that had been made, identified some further improvements that they would hope to see, but gave a confident view that we were heading in the right track with the new team. They did highlight as well as the risks of some disputed balances, which I think, as Claire reported earlier in her finance report, some of those are now materialised and are in our position. It wasn't material to the accounts, but it was of great significance, and the external auditor spent quite some time at the audit committee stressing what they thought about the potential risks of that and the process we need to take in future years. The annual audit letter was discussed, and we've attached that to this paper. I think it's a fairly clear summary of the external audit work during the year, and it reinforces the previous messages to the governing body. Particularly, they were very exercised by CHC processes, and we did have a bigger audit bill this year because of their concerns from last year. And we did outline the work that Chris had started to do already and what our expectations were about trying to stabilise the position. They did notice the improvements that they'd seen compared to the previous year, but they're still looking for further evidence. And we had I think whether we've had it yet, but we were expecting to get a further invoice from them because they had to do additional testing. So there is an onus on us to get sharper with the arrangements for broad care and then the links between CHC and the finance department. Their concerns, I think, would apply just as much to patients as it would to finance, because a lot of this was about clarity of information flows as well. And then there was a discussion earlier in this afternoon's meeting, but we did ask for an extra report from internal audit about contracting of related finance arrangements, which did raise some significant concerns. Aside from the normal processes, David suggested we had an internal meeting which both Kevin and I, as chairs of the audit and the finance committees, attended, just to get some assurance about the actions that are taking place. I think to some extent, I think we were reassured by that, but we have asked for a further update at the August Audit Committee, and we expect to ask appropriate questions at future finance committees to make sure that we're happy that the arrangements are robust enough to give us sufficient information. None of this would have been material to the account, so it's not going to have an impact on that in the future. But it's about the certainty of the information that comes through and about making sure that we've got proper processes embedded in both departments. So we're carrying on in the review of that, and I think we feel, at least to some extent, reassured that some of the right actions are in place. We just need to be sure that there's sufficient pace with that, and then to get the assurance that they're actually delivering what we need. I think that's probably as much as I want to say on this. Claire, there's anything you wanted to add?
Nothing to add.
No. Any questions that anyone's got?
Any questions? My question would just be for David and Claire. Obviously, Keith's report has commented on some changes or some issues that were raised. I'm just wondering what sort of steps have you taken to actually to remedy those issues that were raised in the report?
So the kinds of issues that came up were about ensuring we had clarity of roles and responsibilities, particularly in the contracting team, finance team, where it would appear there was at very least uncertainty about individual roles, and basic controls really, so being clear on reporting, being accurate, being clear on authorisation to sign things off and so on. So there's been a lot of work gone on in terms of supporting our staff on understanding their respective roles and responsibilities, codifying that. So one of the actions we agreed was making sure that was properly captured in a simple, brief way rather than complex policies and the like. So I think that's in hand. And being confident that the level of reporting, particularly to the Finance Committee, was had in effect early warnings of problems and was at the right level of specificity to not simply glide over what potentially were quite big, small in the scheme of things, but quite big individual numbers and so on. So I think so the critical actions were making sure our reporting to Finance Committee is clear and with sufficient detail to give assurance and to ensure that those kind of roles and responsibilities are pinned down effectively, so there's no ambiguity about who's got authorisation to do what in which setting. But it was that type of issue, so Claire, you might want to add to that in terms of detail. So Claire worked with Gail on this specifically.
Yeah, and I think the other aspect as well was in terms of making sure that we didn't just focus some of those actions on those two teams. It was about embeddedness of understanding and roles of responsibilities throughout the broader organisation as well. So tomorrow at the staff briefing we're launching a programme of training that we will be ensuring that all budget managers and budget holders attend, but it's open to other interested staff within the organisation, and again that will give a particular focus on levels of authority and what it means to individuals to be a budget holder and what responsibility that conveys to people. There's also quite a bit of work that's happening within the contracts team already and will be strengthened with the arrival of a new joint appointment, a senior lead within the team that starts She starts at the beginning of August, and again they're reviewing process, procedures, and just generally making sure that we're tightening up wherever we can. We've got our internal audit programme as well that will sort of support that through the year. So where we're implementing change, we've got a way of testing some of that as well to check that it is robust.
And likewise, we have got the HFMA, which is the Healthcare Finance Management Association training. And one thing we've asked the staff to do that, but also it is available for board members to do. So I think the take-up has not been huge at the moment. But I was asked last time to flag it to board members to remind them that they can do the HFMA training modules. Colin may not know about it because he took me blankly. But it was something we arranged a few months ago where we purchased a training package for the whole of the CCG, which has got a variety of modules that you can choose to do that actually increase your knowledge or awareness of different aspects of healthcare, finance. So I'd like to, we can resend the... Sorry?
Sounds like a broad hint in my direction.
No, not you. I actually think the take-up's been incredibly low.
You've joined since the original invites went out. So
no, not at all. I'm just saying you didn't know about it. I think if Sam could perhaps recirculate the information to all the current board members about their logins. But thank you for that. I mean, there's a lot of positives also in the audit report, I think, year on year, but a lot of challenges as well. And the frustrating bit is the challenges that are the same year in, year out that we haven't addressed. So.
Apologies. Can I just note that the audit report that's within the public papers is the draft report. And the only reason it's draft is that there's a comment in there on page 11 that Claire and Laura are going to update a section. That was the only thing that changed. The final version was with the audit committee papers. I've just checked, so we just need to update the public document because we've
pinning down exactly which was
we
the right
can
one.
put that in, but it is only a single paragraph in there that changed. There's nothing else fundamental.
Okay, so we'll put that into the paper.
So thank you for that, Keith. Unless there's any further questions. We then move on to a series of papers that are there for information and exception reporting. So I won't read out the papers that are there on the list. Has anyone from the board got any questions about any of those papers? If not, I'll move on. I've had two AOBs notified to me by David, both just brief updates. The first one's about information for the board about PCN formation, and the second one is about the long-term plan implementation guide that's been released.
Yeah, so board members are probably fully aware of the PCN process and the decision-making goes through the Primary Care Committee. It will come back in minutes of future meetings, but given we only meet every 2 months, I thought it might be worth just flagging up that we have now put in place 4 primary care networks across Shropshire. If people, I think a briefing's gone out. Have board members seen a briefing on? Yeah. So you've got details of it, but that it wasn't the most straightforward process to get those agreed. But I'm pleased to say we hit the deadline that NHS England had set, and they are now up and running. It's worth saying they're in very early form, and we should be careful not to have overinflated ambitions and expectations of the primary care networks, but it's an important first step in part of a new architecture of the NHS for the future. And the second thing, so that was just for information really, and as much to make sure it's noted publicly as for you as board members. The second issue I just wanted to flag was we've now, in the last couple of weeks, had the long-term plan implementation guidance published, which requires every STP area to submit a long-term plan implementation plan. So this is the 10-year plan, that came out in January. We now have a requirement to submit an implementation plan by November this year, setting out our collective implementation plan across the whole system. So clearly we as a CCG are one of several partners in the SDP who will need to work together on putting that long-term plan submission in. So I think it interfaces quite significantly with our commissioning intentions and so on. So if people would find it helpful, I can circulate the full, it's about 70 pages long, I warn you, implementation requirements.
There's a quite helpful HFMA
summary
that I could...
That sounds perfect. An HFMA summary, which is hopefully rather shorter. Yeah, so perhaps if we circulate that to board members, just so you get the flavour of the sorts of things that we're going to have to work on As I say, it interfaces with our specific commissioning requirements, but we clearly need to work in the context of that long-term plan. So I just really wanted to again bring that to your attention.
Okay, thank you. Meredith?
Just interested to know how the process for developing that plan. Can we have some sort of engagement exercise for the governing body to inform that, rather than it being something we might respond to?
Yes, I think, so ultimately, the STP, as you all know, have no statutory existence at all. It's a partnership, it's not a body. So given this is a submission on behalf of all organisations in the STP, what the proposition is there will need to be a sign-off of that submission from the boards of every organisation. So at end point, there clearly will be a requirement for us to receive and endorse, stroke support, stroke sign-off, I don't know what the verb will be yet, the submission. In the shorter term, and probably more fundamentally, the process for developing our commissioning intentions, that we have said we will hold a development session with governing body members to support the development of that, and through our clinical commissioning committee and so on. We need to make sure that work includes the requirements of the long-term plan, so that our plan and that plan are not two separate entities but are one and the same thing. So there's a iterative process clearly we're in, where we're working with partners and working with our own governance systems, but we need to bring the two together.
And perhaps a way by which we can secure the involvement of patients in that working up process?
Yes, I mean, we, as you know, because you drafted it, we signed off our process for engagement of patients and the public in our development of plans, and we need to make sure that the work that we're doing in a system setting is in line with that ambition. So where we've got boards and so on working these proposals up and plans up in a system setting, we need to ensure there is proper engagement in their development. And there is as you might remember, there's a whole communication and engagement work stream of the STP, which is ratcheting up its work at the moment to ensure that there is effective engagement in the development of these plans.
And it was something flagged in the Health Select Committee when they were reviewing some of the plans recently in their recent meeting, was the suggestion there needs to be more public involvement and visibility of the STP ICS process, so that is important.
And true, some of this is clearly work in progress, and we're developing the process for doing it and the content simultaneously, which is probably not ideal, but is the place we're at in partnership working. But my general sense, and from what everyone tells me, obviously I wasn't around last year and in previous years, but the degree and the effectiveness of partnership working seems to have ratcheted up significantly in the last 2 or 3 months, to a point I'm a bit, I think people generally, rather than me, are a bit more confident we're working together effectively as a system on finances, on planning, on clinical relationships between the different organisations and so on. So my sense is we're in a much stronger place than we would have been if we were having this conversation even 6 months ago. But we're playing a bit of catch-up in truth. So I think the processes we're using are probably somewhat imperfect, but I'm pretty confident are stronger than they would have been had we been trying to do this in previous era.
Thank you. So unless there's any further comments, that's the end of the meeting. Our date of our next meeting is Wednesday, the 11th of September, at a time and venue to be confirmed. So thank you very much for attending the meeting and for attending the AGM. Thank you. I'm not sure that's right. We're happy to talk to you afterwards the meeting's ended, but if you want to come and talk to us, that's fine. But we don't recognise that figure of any drop in the funding because it's our money. But very happy for